Hello, I'm Walter Zaharodny, lead author of the article Preliminary Evaluation of a Brief Autism Screener for Young Children. As a clinical psychologist and researcher involved in tracking autism prevalence, I'm very interested in advancing the early identification of autism. Even though the early developmental pathways of autism are well described and most parents report concerns during the second year of life or earlier, we know that many children with autism do not come to attention before school age. Moreover, autistic children from low-income and minority families are less likely to be identified before age 3 and therefore are less likely to receive early intervention services. This is especially distressing as a growing body of research indicates that early interventions can yield significantly improved developmental outcomes and may enhance the quality of life of many children with autism. In spite of broad and growing awareness of autism, and despite the recommendation of the American Academy of Pediatrics to screen all children for autism at 18 and 24 months, no autism screening tool satisfying the requirements of validity and efficiency has emerged. Our group endeavored to design and then evaluate such a tool. We wanted the new autism screener to be based on parent report and to have good ability to identify true cases of autism while avoiding false positives. We wanted the screener to be useful over a significant expanse of the toddler period, for 18 to 36 months, for example, and to be effective without regard for the family's socioeconomic level. To be useful, to have a chance of broad adoption by pediatricians and family practitioners, we also understood that the test should be brief and easy to administer under primary care conditions. Using information provided by the parents of autistic children and data for many cases of autism identified through surveillance activities in New Jersey, the investigators developed a 10-item questionnaire, the Psychological Development Questionnaire for Toddlers, or PDQ-1, to be completed by a child's primary caregiver. The PDQ-1 questions mainly focus on the expression of early social communication skills and interest. Each question is scored on a 3-point scale, and all scores are summed for a PDQ-1 total score. Parents can complete the PDQ-1 in 2 minutes or less, and it can be scored using a standard schema in the same amount of time. In the early pilot phase of our research, we determined that low PDQ-1 scores were associated with positive autism diagnostic findings on established autism tests, like the Autism Diagnostic Interview for Research and the Autism Behavior Checklist. And we defined a likely cut point or autism risk threshold score for the PDQ-1. In the next, that is the prospective phase of our work, children age 18 to 36 months attending multiple cooperating primary care practices in Essex and Union Counties, New Jersey, were screened with the PDQ-1. We excluded children with known or suspected developmental delay and/or disorders associated with delay. That is, the screened children were typically developing or low-risk toddlers. Parents of children whose total PDQ-1 scores were in the risk range were invited for a comprehensive and expedited developmental evaluation and referred for intervention services as needed. Parents of all screened individuals were interviewed when the children were between 4 and 5 years of age and provided information on their child's development, diagnostic status, and use of services through a standard process. We analyzed the screening and follow-up data to assess the sensitivity, specificity, and positive predictive value of the new test at different points between 18 and 36 months. So ultimately, we screened and followed 1,959 toddler-age children with a PDQ-1. Screening was broadly accepted across all cooperating practices. Approximately half of all screened children were from low SES communities. A relatively small number of children scored in the PDQ-1 autism risk range. The PDQ-1 identified children with autism from low, middle, and high SES communities who were without previously suspected delay or developmental problems. Our findings show that across screened children, the PDQ-1 had overall sensitivity of 85% and specificity of 99%, indicating that the new test has good ability to predict true cases of autism and excellent likelihood of avoiding erroneous detection in a low-risk population. This study is important and I believe exciting because it provides strong, though preliminary, evidence in support of the PDQ-1, a new brief parent report screener which may be effective at identifying young children with autism from the general population. In this study, the PDQ-1 showed good validity by conventional measures of sensitivity and specificity and identified previously unsuspected cases across communities. The PDQ-1's brevity and ease of administration are compelling advantages and commend its use across real-life primary care conditions. The observed findings may be sample-specific, however, and caution is indicated before broad clinical implementation of the PDQ-1. Additional research and replication is recommended with unselected populations and to determine test characteristics for children with already known or suspected developmental deficits. I'd like to take this opportunity to thank my co-authors, Josephine Shanuda, Patricia Garcia, Emily Yee, Madeline Goldfarb, Mangala Rajan, and Uday Mehta. I also thank our cooperating pediatric practices, as well as the caregivers and children who participated. This research was made possible with support from the New Jersey Governor's Council for Biomedical Research and Treatment of Autism, the Healthcare Foundation of New Jersey, and the Pediatrics Department of Rutgers, New Jersey Medical School. I thank you for your attention and invite you to read the full article. Above all, let's continue the important conversation about improving the early detection of autism.